another Friday RLR, but unfortunately Sans 1R today. Prof Rez is traveling today, so won't be able to join us. And so instead of Reza, I was trying to think like who would be able to fill his shoes. And I think the answer is no single human being can fill the might of Prof Rez. So we're actually going to have a conversation with the whole chat today. So I will try to kick it off and talk first and see what thoughts and comments accumulate in the chat, and then we'll try to share them. We do have to end a little bit early because I'm on service and have to head into work, but we'll still have a lot of fun nonetheless. So as always, please let me know who would like to step into the lukewarm seat of sharing some learning with us. It is the greatest gift to the CP Solvers community when you have a case that you would like to discuss. Also, if you don't have a case but are still here and can turn your video on, it goes a long way. It's, as you probably have seen on Zoom, when you're able to see people, interact with people, it's way better. It almost feels like, while I understand it, I turn my video off most of the time. It almost feels like you're in a room with people and they're like looking the other way. So look towards us, please, if you can. Hans, MK, Kirtan, Justin, Yusuf, Darlington, Julia, Allah, Jana, anyone have a treat? Any learning they would like to share? So tempted to share some cases that I have, but I promised Prof Rez that I would save them all for him. And for you, if you are on RLR. Hi, Yusuf. Good morning. Or wait, no, good afternoon. I see the clock right behind you. Thanks for joining. Hi, Kirtan. Wow. You know, the interview, those are your roses from interview season, right? Behind you, or am I?
I know, right? Exactly. So like I feel that I'm in the same place that I was like maybe 1 year before. I'm at home, I'm enjoying the CPS, while anxiety is building up. So thanks for organizing this meeting. Looking forward to today's case.
It's so good to see you. So good to see you. Hi, Justin. I see you turn your video on. I don't think we've met before. Do you want to say a quick hello if you don't mind?
Yeah, hi guys. I've been lurking in the background and had a chance to get a camera on my screen, so nice to meet everybody.
That's awesome. Tell us a little about yourself, please.
Yeah, I'm fourth year, just submitted for residency spots, so did the rank list. Yeah, so just waiting on that.
Congratulations. It's you're near the finish line, my friend. Where are you located right now?
I'm actually, so my partner, she's in family in Martinez, so I'm actually in Martinez, California, the Bay Area.
Cool. Yeah, no, you're minutes from here. That's so cool. I live in San Francisco.
Oh, nice.
Are you hoping to stick around in California, or do you apply broadly, or what does the future, dream future, look like for you?
Yeah, that's the plan, to
cool.
Hopefully stick around.
Amazing. Wonderful. Well, thanks for hanging out today. And I'm sure intern year will bring you many a case, and hopefully we get to hear learning from you at some point in the future.
Thanks so much. Yeah, sorry I don't have
I'm
cool. Not really in the clinic right now, so
no worries at all. No worries at all. Hi, Gitu, long time no see.
Hello, how are you doing?
I'm doing well. How are you? It's so nice to see you.
Nice to see you guys too.
How have you been?
I'm doing all right.
Good. We're glad to hear that. Thank you for joining us.
Of course, I follow up on YouTube, so
yeah. Yeah, no, it's so nice to see you. Welcome. I see that Yusuf has a gift for us, but I see you're also in motion. What's up?
I do have a case, but I'm in the room that they do noon conference in, so I just have to move to the room next door.
Oh, no worries at all. Take your time. There's no rush. That's very, very kind of you, Yusuf. We really, really appreciate the commitment to presenting. You too. I don't want to be. I'm not 100% sure because it's been a while, but you're a practicing nephrologist. Is that right?
Not nephrologist, hospitalist.
A hospitalist.
Hospitalist. Yeah.
I wonder if you threw some epic nephrology pearls one day that made me mislabel you, or my mind is inherently crazy.
I think that's the case.
Yeah. Do you like nephrology?
I think I like medicine in general. No, no particular specialty.
Nothing incredible. You and me both.
All right, good. That's why we are hospitalists or
I know,
ED
exactly.
or.
Exactly. Oh, by the way, I don't know. Ravi just showed us a special surprise. There's been return of a famous morning report legend. You can only see his left ear right now. Hello, Rafa's left ear. Why are you hiding?
You know I'm shy, right? No, not true.
Your left ear is bold and ambitious, but the rest of you is pretty shy. All right, Yusuf, take it away, my friend.
Hello, everyone. I have a case that I've actually seen a couple of weeks ago on wards. I'm obviously going to change some of the details for anonymity and for HIPAA purposes, and hopefully it'll be a good case to discuss. This is the case of a 18-year-old male with no past medical history, presenting for 2 weeks of fatigue and lower extremity swelling.
Oh, Yusuf, what an intriguing start. That's a master presenter. And I think that immediately the task that you're giving us is to decide which of these two concerns to begin with. And the specificity of fatigue is minimal. The specificity of lower extremity edema in an 18-year-old is very high. That's because the non-specific diagnosis of lower extremity edema in older adults would be venous stasis. That occurring in an 18-year-old would be very unusual. The DDX of fatigue is infinite and is really just a barometer of how bad the problem is. The more fatigued the patient is, the more I worry, but I don't know in which direction to worry. So I think the key part of the analysis is to focus on the lower extremity edema. And the first question is to understand it. We know the time course, 2 weeks, but we don't know the distribution. Often, though, I think when we code it as lower extremity edema, what we're usually encoding is bilateral disease. Unilateral disease stands out to us more often, and we're more inclined to say the word unilateral, but I'm curious, Yusuf, what is it? Is it unilateral or bilateral?
It is bilateral.
Mm-hmm. Yeah, that tends to be the case when we code it as leg edema. And I think the immediate question when you're seeing this patient is to look up and away from the legs. And if you see a cardiopulmonary signature or abdominal signature or a subtle but important renal signature, that's what I would do. So maybe Yusuf, we can try something a little bit different in this case, if you're amenable, is just to really give us the data that we ask for. So because I can tell your command of the case is very good. So maybe in the chat, ask for stuff that you want, and I'll request data from Yusuf. And if you don't have it, that's totally okay. But honestly, what I'm really curious to know next, and what would probably happen next in real life, is to know what the vital signs and what the exam are. Do you have that data?
I do. Awesome. So the temperature was 37.0. His heart rate was 85. The blood pressure was 145/85 with a normal respiratory rate and an O2 sat.
Excellent. And do you want to just give us the initial exam as well? And we'll
absolutely. So he's a 18-year-old male, not overweight. He was lying there in bed, essentially, not in any respiratory distress or without any increased work of breathing. He was in his shorts when I first saw him, and he actually had the swelling that went all the way up from both legs, all the way up to his thighs. And it was pitting bilaterally without any rashes or discoloration. And then his cardiopulmonary exam and his abdominal exam were essentially normal.
Excellent. Yeah, I'll just share my thoughts real quick, and then I'll see what the chat says. And honestly, Yusuf, would love to tap into your in the moment reflections when you were at this juncture yourself. For me, I think this patient is having alarming symptoms for renal disease, and let me tell you why. I hope that somebody will publish this soon, but when you're trying to study between heart, kidney, and liver, the normal blood pressure makes a liver cause much less likely. Most people with advanced decompensated portal hypertension, enough to cause this degree of edema, usually have hypotension. So the liver is off. And then honestly, what I do is this ratio of blood pressure to pulmonary involvement to degree of edema. Most people who have a high blood pressure in the context of heart failure have very prominent pulmonary involvement. So this person who is slightly hypertensive, if their heart was on the hook, I would expect them to be hypoxemic and dyspneic. And the extreme form of that is flash pulmonary edema, when somebody's almost about to be intubated secondary to the hypertension. It's also true that patients with kidney disease tend to have more edema, more hypertension, and less pulmonary involvement. So because of the edema being so high and the blood pressure being notable and the lack of pulmonary involvement, what I really, really want to know next is one test. And that one test is his serum albumin. It's not his creatinine, and it's not his urinalysis, because the creatinine in patients with nephrotic syndrome can be normal, and the urinalysis is actually pretty noisy. It's a function of blood pressure. It can distract you. So Yusuf, maybe you can tell us his albumin next, and then share with us what you were thinking at that juncture.
Yeah, so when I first saw the patient, like you're saying, I automatically was thinking kidney, liver, and heart. But my system one thinking was like, please don't be a cancer that is intra-abdominal that's causing the swelling. And I wanted to rule that out immediately. And that was like the red flag that was buzzing in my head in this young patient. And I wanted to rule that out just as like not as a common factor, but just as something that I don't want to miss. So I immediately jumped to like asking them the questions of like the B symptoms questions and things like that. But obviously keeping in mind that the most common things are kidney, liver, and heart as in parallel as I was doing the exam. So to add to the history, so he did not have any fevers, chills, or night sweats. He has not had this before. And he just gradually noticed that over the past 2 weeks, he was having difficulty raising his legs. And then he noticed that, oh, they're actually swelling. And this is essentially progression until to the point where he was dropped to the emergency room by his grandparents. It was like very sweet. And they were like sitting there. Jumping to the labs that you requested, the serum albumin was 3.3, with the lower limit of normal being 3.5 in the lab that we in our lab.
Excellent. Why don't we just pause here? And I'm curious, what other data are you all interested in the chat? I'll just wait for 30 seconds and see what we. I think Hans is appropriately saying, yeah, that's low, but not as low as we'd expect. Kirtan is locking into the renal hypothesis and saying, given the age, he's worried about, he's prioritizing his nephrotic syndrome DDX, and Adam is hoping to know the creatinine next. So it seems like we're still, and then Justin is hoping to see if there's proteinuria. So, and Anne-Marie is triaging the kidney involvement to want to know what the creatinine is and what the platelets are. So I think now I'll just share my thoughts. So the albumin not being as impressively low as one would expect in marked nephrotic syndrome, I think you have to pivot to say, is it not renal at all, or is it the nastier version of glomerular disease? Is it nephritic syndrome, in which the albumin is not as impressively low? So I think for me, I'm still most worried about the kidneys, and now would be most interested in the UA and the creatinine. The UA more important than the creatinine, because the creatinine can be normal in early glomerulonephritis. So I think the next test maybe that I think the consensus is on that has showed up the most is the UA.
Yeah, so the UA was without any leukoesterase, nitrites, or WBCs, and it was a 3+ protein. The creatinine, it was 1.2.
1.2. And was there any red blood cells on the
No red blood cells.
Okay, all right. Yeah, I think I think in this situation now, I think you have to lock in on the possibility of nephrotic syndrome with that amount of proteinuria and no hematuria. And it just goes to show you that the albumin is technically low, and we might be used to seeing more adults who have more decompensation with similar disease physiology. So Yusuf, what were you thinking at this time?
So like you all are thinking, we were like, given the age and the proteinuria, could this be nephrotic syndrome? So we wanted to go ahead and like proceed to get the urine protein and the creatinine. And then we started asking my branch point for nephrotic syndrome is like primary and secondary. So I started screening for risk factors for secondary nephrotic syndrome.
Excellent, excellent. So Yusuf, that is so cool. I love for you all in the chat. Now you have a working problem representation. What I'll say, you have an 18-year-old man who presents with the subacute development of what appears to be nephrotic syndrome. So Motaz wants to know meds and social history. Beautiful. What else do you want to know, y'all? It could be any data point. You could ask for a specific lab, ask for a specific piece of history that is not revealed. What do you want to know? Yeah, Andrew's emphasizing that the testing pathway that Kirtan outlined earlier to think about the histological diagnoses is really, really important. So membranous, minimal change disease, and a history of traveling, medication exposures. Do you have any of that data, Yusuf?
I do. So they're from Atlanta, Georgia. No past medical history, no recent travel. Has been in Georgia their entire life. They are starting college starting college soon, I believe. No history of any substance use, or they're African American and has been in Georgia their entire life, and does not take any medications. No smoking or alcohol use.
Mm-hmm. Excellent. And Anne-Marie, I think, was wondering about sexual history, HIV and syphilis being the most common overlap with nephrotic syndrome.
So on initial exam, he initially was like a little bit shy and told us that he's not sexually active. But on like the third day, on the fourth day, after we like built rapport with him, he said that he's had multiple sexual partners in the past year who are both men and women.
Gotcha. Yeah, I think that piece of history is very, very helpful, but honestly, it probably shouldn't influence your testing. It should influence your pretest probability of whether the test is positive or negative, because all patients with nephrotic syndrome should probably get the slew of infectious workup. And Andrew and Kirtan have both shared fantastic approaches in nephrotic syndrome, naming specific diagnoses like membranous nephropathy, minimal change disease, and focal segmental glomerulosclerosis. And I think it goes to show you how often we need pathology to diagnose nephrotic syndrome. Those are all histopathological entities. The last important one to know is amyloidosis, both AL and some renal specific amyloidoses. But I think you can stratify the probability of what kind of histological finding you'll see based on other clues. So what clues can we use in this patient? I think the fact that that this developed abruptly would be most consistent with two diagnoses. It would be most consistent with minimal change disease. The name minimal change disease is a great name because it tells you that the disease process happens so quickly that there's often not any macroscopic histological changes, and the podocyte issues that occur need more refined imaging like electron microscopy. So minimal change is usually maximal in its intensity and is very abrupt in onset. Focal segmental glomerulosclerosis is important to think about given the race, though I think we have to be a little bit more careful with using race as a proxy for genetics. So studies would tell you that association between African American race and focal segmental glomerulosclerosis exists, but I think those studies are probably imprecise in their proxies for genetic analyses. So I don't really know what to do with that data. I don't know how valid it is. I bet it's not very valid. Membranous nephropathy is the most likely form of nephrotic syndrome to result in a relatively normal creatinine, though it tends to be more subacute in onset. So you have features consistent with all three. Minimal change disease is creatinine is relatively normal. Focal segmental glomerulosclerosis if you're using race as a proxy, which isn't great. And then minimal change given the abrupt tempo. So you're back to thinking about all of them. But I think the secondary workup to look for triggers is really thinking of the 4 infections: Hep B, Hep C, HIV, and syphilis. It's really important not to forget syphilis. We often triage that lower, but it can equally likely to cause membranous nephropathy. And then sending ANA serologies for the possibility of lupus. And then finally, in patients who are at risk for membranous nephropathy, which is really all patients in nephrotic syndromes, more and more so, many labs have the ability to send the phospholipase A2 receptor, which is literally the perfect biomarker. It is sensitive, specific, and correlates with disease activity. So I think we're diving into the world of nephrotic syndrome, Yusuf, here with that workup.
Yeah, and that's exactly where we were as well. So we went ahead and ordered a HIV antigen antibody test that was negative. We confirmed with the patient their last sexual activity, and they actually reported sexual activity within the past 2 weeks or within the last month. So we went ahead and ordered the PCR anyway, which was also negative. We ordered the hepatitis panel that was negative as well, and then RPR that was negative. We ordered the phospholipase A2 receptor antibody. It did not come back immediately, but it was negative. At this point, we spoke to nephrology which was within the first day of admission. We spoke to nephrology and hopefully to plan towards a biopsy.
Amazing, Yusuf. I'm just curious, maybe to get your insight on something which we don't usually get. What was your role in taking care of the patient? What were you the resident, the intern on the team? What was your job?
I was the resident on the team.
You were a resident, amazing. And what was it like for you to take care of this patient and take this 18-year-old previously healthy person through this journey?
One thing that I'm fortunate enough to do is that, or what is not known about residents, is that residents that can spend more time with patients because they're not rushed to see all their patients and immediately. So I had the fortune of being able to sit down with the patient, build rapport with them, take a lot of social history. We became almost friends. We talked about everything, and we tried to normalize it as much as we can, and trying to get through this hospitalization as fast as we can. So I was fortunate enough to be able to spend time with them.
That's amazing. That's so cool. I'm so glad to hear that. Yeah, I think from a diagnostic perspective, I think you're showing us how powerful biopsy is in these patients. So our systemic workup is nearly complete, though the ANA would probably round that up. There is some recognition that other autoimmune diseases can also cause nephrotic syndrome. And they're very rare. It's a very rare manifestation of IgG4 disease. Sometimes sarcoidosis can cause nephrotic syndrome and mixed connective tissue disease, but the patient doesn't have any stigmata of any of those diseases, though lupus can definitely sneak up on people. And I think in this situation, it's probably a good idea to send off an SPEP to see if you can diagnose light chain amyloidosis, though the age of the patient makes that much less likely. There are some hereditary forms of renal predominant non-AL, but other forms of amyloidosis that you really only can realistically diagnose on biopsy. So I think one thing that really comes up is what are the risks of renal biopsy? Because tends to be some hesitation with this procedure, but the risks are infinitely low. Definitely worth the diagnostic clarity that would come from this case. So I think we're probably moving towards biopsy. But Yusuf, I'd love for you to teach us on what you were doing to manage this patient while all this was happening. How did you support the patient as physiology while you were waiting for diagnosis?
Right. And as you all know, like patients with nephrotic syndrome have volume overload, but it can be difficult to manage the volume overload as you would want to give them some diuretics, but at the same time, diuretics have a decreased efficiency with given the low albumin. In this case, it's not that significantly low. There are some strategies to try to mitigate that. There are some people who recommend using Lasix or furosemide in a TID fashion at a lower dose, like 20 TID, for example, or sometimes it's through IV diuretics. We conferred with nephrology who were managing with us. So we were actually giving IV diuretics concomitantly throughout this workup process, and his swelling was improving gradually from day to day, essentially. And the other thing to think of is the procoagulable state with nephrotic syndrome, that you lose prothrombin 3, so you or antithrombin, sorry, and then you would want to give them anticoagulation as well. So we were giving regular anticoagulation.
Amazing. I'm so humbled by your command of the details, your command of the patient's unique social circumstances, including the fact that their grandparents dropped them off, and it's excellent management. What happened next diagnostically?
So we were planning for a biopsy. We also got a bunch of other labs. We got the SPEP, UPEP, like kappa to lambda ratio. The SPEP was normal. The UPEP had not returned when last I checked. We got an ANA that was normal, a C3 and C4 that were normal, rheumatoid factor that was normal, and ANCA that was normal as well. And the nephrology proceeded to biopsy, and the biopsy was consistent with membranous nephropathy. We have one more aliquot.
Amazing. Amazing. Oh, wow. Well, we now have a specific diagnosis. We have membranous nephropathy. And I'm curious what you all think about that. What does that do for you? Andrew's asking actually, before, I wanted to share a great pearl that AMK threw out in the chat about in patients who have advanced renal disease. She was sharing her experience that nephrology gives DDABV to reduce the risk of biopsy. It was a really cool pearl or pair, AMK. And then now folks are wondering, is this primary or secondary membranous nephropathy? And I think there's a couple of things to reflect on here. So there are other the serological workup for membranous nephropathy includes phospholipase A2 receptor, which is negative here. The interesting thing to know that does not mean the patient doesn't have phospholipase A2 receptor disease. About 70% of patients will be seropositive, and 15% will be seronegative, but will stain for this receptor on the histopath. So a total of 85% of primary membranous nephropathy is positive for phospholipase A2 receptor, and 15% of those patients only show up on histopathological staining. There are other biomarkers of primary membranous nephropathy, and the most other one is Th7Da. It is a biomarker that is important to know because it actually portends a higher risk of associated cancer with the membranous nephropathy. So long story short, I think when you have a diagnosis of membranous nephropathy, it's tricky. We have ruled out the infections to, within the performance characteristics of serology, we've ruled out the infectious triggers. We've made the autoimmune causes less likely, but we have not excluded malignancy. And so it's important to think about the possibility of malignancy in this patient. And I think, I think that what I would probably do in real life is scrutinize the other data. Like, did we overlook a microcytic anemia, or did we do a testicular exam? Like basic things. I don't know if we're supposed to go fishing for a cancer in this situation. I'd love to learn from what Yusuf's experience was. But my next steps with the current knowledge that I have would be to wonder what the phospholipase A2 receptor staining was on the tissue, to send the other serologies for primary membranous nephropathy, and then to wonder what the correct thing to do is with regards to how deep to dive for a cancer associated with membranous nephropathy. What happened, Yusuf?
So one of the tests that we had ordered came back positive, which sort of like was like sort of a pivot for us, and that was the treponemal antibody test. So the treponemal IgG, I believe, in the serum was positive, and this will essentially reveal the diagnosis. But we communicated with the lab to see if we can do like a Prozon effect on the RPR, and after doing the dilution for the RPR, it came back positive as well. So the presumed diagnosis was a membranous nephropathy secondary to syphilis, which was treated by with IM penicillin for 3 doses. Essentially, I just went and checked, and the patient was followed up in clinic afterwards. And from the documentation, it seems like they were doing okay since then, have not had any issues with swelling, and were recovering well from that hospitalization.
Absolutely amazing case. I definitely have some things to reflect on, but I would love for you to teach us on the prozone phenomenon, because I clearly looked for it. So please enlighten us.
So essentially, for some tests that involve antibodies and antigens, the mismatch of the ratio between antigen and antibody may cause a false negative test. One of those tests is the RPR, in that if the antigen is more than the antibody, it's sort of related to the testing technique, but the watering down of the test would cause the test to seem negative. But if you dilute it even more, you keep diluting the sample where you have less sample, the test will come back positive counterintuitively. And in cases where you have a high suspicion for syphilis, for example, you can ask the lab to do the Prozon effect or dilute the sample, and that may reflect the test as positive.
Absolutely outstanding. It's so cool. And I think it highlights so many things about syphilis. One, how sneaky it is, how it's important to keep it on the list for membranous nephropathy. And then I think it goes to show you why testing in most institutions in the United States starts with a treponemal antibody test. So now we do reverse syphilis testing. And I'm glad that you got both, because each test is flawed. The treponemal test is flawed because it is always positive. It never turns negative. So if you have a patient who's getting syphilis for the 3rd time, it'll remain positive, and you won't be able to distinguish it from the first time the patient got syphilis. RPR could be false negative in 2 situations. One is the patient has long-standing disease and has had it forever, or 2, the patient has a high burden of secondary syphilis, which is exactly exactly the patient in whom membranous nephropathy occurs. So, Yusuf, I asked some subtle clues. Now it's all about subtlety. So, in retrospect, was there a rash, and what was the alk phos? Because many patients have subtle liver involvement when they have kidney involvement.
Right. So there was no rash, and for the alk phos, I would have to go back and look actually.
Oh, no, it's okay. No worries at all. Absolutely incredible case. Thank you.
The
so
alk phos was normal.
Was normal. Wow. Yeah, this is, I mean, it's humbling to have purely isolated membranous nephropathy with Prozone effect. I think it just goes to show you how how medicine will stress your clinical reasoning infinitely, and makes me worried about the sheer number of people who might have been misdiagnosed. Because I think, Yusuf, it's so fundamentally clear to all of us listening to your presentation that you are an outstanding doctor, not just in your command of clinical reasoning, but also in the way you're teaching us, and also the way you seem to get to know your patients and work with your team. And I'm really glad this patient bumped into you, because I wouldn't be surprised, and I wouldn't fault anybody for forgetting to send the syphilis test in a patient with membranous nephropathy. It's so rare, but I think in the context of the sexual history, it's even more important. But I think we should send it in everybody. So thank you for this great reminder. And honestly, kudos to all 24 people who are here alive and everyone who listens on YouTube, because it's this kind of case that will make sure that you don't make that mistake that unfortunately commonly happens. So I'll pass the mic to you, my friend, for any final reflections you want to have before we learn from Leah.
Thank you so much. I think the interesting thing is here we assume that secondary to syphilis. We don't know if it's like a primary membranous nephropathy and the person also has secondary syphilis. So we made a leap. I don't know if there's like any other staining we could have done. And after our reading, it seems like all the cases of membranous nephropathy secondary to syphilis seem to be reversible with treatment of the penicillin. So that's something I'm looking forward to, is hopefully like we can monitor for progression, hopefully if we do the treatment, and then that can also tell us in retrospect if this was actually membranous nephropathy secondary to syphilis as well.
Absolutely amazing. Yusuf, can you believe we did all that learning and teaching in 30 minutes? That's unreal. Really, really appreciate you, my friend. It's been amazing seeing you on VMR. It is a special place in my heart, knowing that we are from the same microscopically small country in the world. It really is. Thank you for joining us. And I'll pass the mic to Leah to recap Yusuf's gift to us.
Yes, thank you, Yusuf, for this case. I think we had a lot to learn, and there were many things that I had never heard of. So it was really, thank you for sharing this case with us and let us learn with you. So to recap this case, I would like to start with first the observation that was made. When we choose a presenting symptom, we choose it by the specificity also, because we want to make progress in diagnosis. So in this case, we chose lower extremity swelling instead of fatigue, because fatigue is really unspecific. And if we have lower extremity swelling, then there are important questions to ask. You want to know the distribution. Is it just one leg or both legs? Because that changes the differential as well. And then what's the time course? And asking whether it's pitting or not pitting is also really helpful, because there are different differential diagnoses for each one as well. And then to make it simple, lower leg edema, look up. Think of the three organs: the heart, the kidney, and the liver. Liver, you might see jaundice or signs of cirrhosis. Renal might have really intense edema also around the eyes that is often described, but you might also not see anything. And then cardiopulmonary signs: is he congested? Are there any symptoms for that? And then the second point was the blood pressure that we looked at, because that helped us already in differentiating these three things. You would expect high blood pressure in renal diseases, or that's more often associated, versus advanced portal hypertension, as in liver disease, usually causes hypotension. So we had leg edema, we looked up, thought of these three organs, and then we saw the blood pressure that helped us even further. And when we found out that this patient had nephrotic syndrome, there are many differential diagnoses you can think of. And some you can have the different causes like HIV or syphilis, or you can think of the histopath name of the pattern of disease. So like membranous glomerulonephritis or FSGS or minimal change disease. And with the workup, you can check the SPEP or UPEP, because light chains might also cause renal damage in association with amyloid, for example. And you have these infectious etiologies. Also think of hepatitis B and C and syphilis and HIV. And then also Yusuf shared this important pro with us that we should consider anticoagulation with nephrotic syndrome, because there's loss of antithrombin 3, which is also a protein, and it gets lost with the proteinuria as well. And there is higher risk of thrombus formation because of that. And this patient had membranous glomerulonephritis, which can have a relatively normal creatinine. So that's why we first thought of it too, or considered it with the other etiologies. And there is this antibody, the phospholipase A2 receptor antibody, that is quite sensitive, specific, and correlates with disease activity, as we learned. And just don't exclude it just because the testing is negative, because there might be cases where it's negative, or it only tests on histopath staining. And then there's another specific antibody as well, the Th1D7A. I hope I typed it correctly, but you have to recheck that. That you can also see with membranous nephropathies. And then now that you have this antibody and proteinuria, which are two things you can already associate with membranous GN, or it's actually not a GN, it's a nephropathy. And then you have to consider, is it primary or secondary? And in this case, it was a secondary cause of membranous nephropathy. So syphilis was actually the cause of this. And yeah, Yusuf also shared some pearls about the testing and why it can be negative, or what can interfere with the testing with syphilis serologies. So we listened to that in order to get that again. Thank you for joining today and learning together.
Hey, you've done 2 back-to-back teachings, and I just love how you're dividing the learning into specific segments, both in terms of the narration and visually. It is, I feel like it's just another notch and another level of like quality of teaching points. So thank you. And yeah, I think you spelled it correct. I just had to double check. I think there's an S in there somewhere, but I said it wrong. So for those of you listening on YouTube, just type that in, and I'm sure that Google will correct it to the right one. But I actually I have to look it up myself. But thank you all. Really, really grateful to all of you for being here, and excited to see you next week. VMR. Bye.